Welcome to this explainer. We love taking complex topics and really breaking them down so you can understand exactly what's going on behind the scenes. And today we are looking at one of the most notorious, brilliant, and honestly devastating cellular hijackers in human history. We're going to decode HIV and the condition it causes, AIDS. We'll start all the way down at the microscopic level of a single cell, and then zoom out to see its real-world impact on the human body. It's a fascinating, incredibly sneaky virus, and understanding how it works? Well, that's absolutely crucial because it's the very first step in understanding how we fight it. Let's dive in.
Okay, so here's our roadmap for today. We're going to quickly cover HIV versus AIDS, then look at the cellular infiltration, map out the timeline of infection, discuss transmission and testing, and finally, talk about managing the virus.
All right, let's kick things off with Section 1, HIV versus AIDS, defining the terms.
So we hear these two terms thrown around together constantly, right? But they are absolutely not the same thing. Establishing this fundamental difference is super important before we look at anything else. HIV, or human immunodeficiency virus, is the pathogen itself. It's the actual physical virus that actively targets and infects the cells in your immune system. Now, there are actually two distinct types, but HIV-1 is by far the most common worldwide. So whenever we say HIV, we're almost always talking about HIV-1. On the flip side, AIDS, which stands for Acquired Immunodeficiency Syndrome, is the condition that arises later on. AIDS is essentially the collection of severe complications, infections, and tumors that happen because HIV has successfully broken down your immune system over time. Simply put, HIV is the weapon and AIDS is the aftermath.
Moving right along to Section 2, let's talk about the cellular infiltration. This is literally a microscopic heist.
Let's really zoom in here to the microscopic level. How does this sneaky hijacker actually break into our body's defense cells? Well, let's walk through the exact mechanics of the break-in. HIV specifically targets immune cells that have a molecule called CD4 on their surface. Think of cells like T helpers and macrophages. Here's how it goes down. Step 1. The virus uses a protein on its outer envelope called GP120 to latch onto that CD4 molecule. But it's kind of like a safety deposit box. It needs a second key to enter. The second key is a co-receptor, usually one called CCR5 or CXCR4. Once it binds to both, the door is wide open. Step 2. The virus injects its single-stranded RNA directly into the host cell. Step 3 is where it gets wild. It uses an enzyme called reverse transcriptase to convert that RNA into a double-stranded piece of DNA. And finally, Step 4. This brand new proviral DNA enters the nucleus and seamlessly integrates itself right into the host cell's own DNA. Just like that, the cell has been officially hijacked.
And that whole mechanism we just talked about, that is exactly why HIV is classified as a retrovirus. Now, the retro part doesn't mean it has some cool vintage style. It refers to this backward transcription process. Normally in biology, DNA makes RNA. It's a one-way street. But a retrovirus brings its own RNA and reverses the whole process to make DNA using that reverse transcriptase enzyme. And guys, here is the truly tragic irony of this disease. When that infected immune cell eventually gets activated to fight off, say, a common cold, it reads its own DNA to mount a defense. But because the viral DNA is now hidden inside, the host cell inadvertently acts like a factory manufacturing and pumping out brand new HIV viruses. It is incredibly, incredibly sneaky.
But you know what? Human biology actually has some wild surprises of its own. Let's look at a fascinating biological loophole. Remember that CCR5 co-receptor we just talked about? The second key the virus needs to unlock the cell? Well, some people possess this amazing genetic twist, a homogeneous mutation in their CCR5 gene. Because of this tiny mutation, their cells just don't have the standard CCR5 receptor. As a result, HIV physically cannot attach and get into their cells. No keyhole, no entry. These individuals actually have a natural resistance or even full immunity to the virus. It's just a brilliant reminder of how a microscopic genetic variation can have massive, life-saving implications.
Now, another crucial characteristic of HIV is its sloppy replication. It's notorious for making errors when it copies itself. It's literally a bad typist. This leads to mutations and slightly different strains forming within the exact same person. This creates something we call viral tropism, which is basically the virus changing its preference for which host cells it wants to target. For instance, early in infection, we typically see the R5 strain. This strain loves binding to the CCR5 receptors, which are found heavily on macrophages. But later on, the virus might mutate into an X4 strain, and this new strain specifically hunts down the CXR4 receptors found almost exclusively on T cells. So the virus actually adapts and changes its target as the infection rolls on.
Let's zoom out a bit for Section 3 and look at the overall timeline of infection. Think of this as the battlefield. When we step back from the cellular level, we can map this invisible battlefield over a timeline of months and years. First up, we have the acute infection, which lasts about 12 weeks. The virus heavily spikes in the blood, and patients almost always experience flu-like symptoms. This is just the immune system realizing it's under attack and mounting a major counteroffensive. This initial fight drives the virus levels back down, pushing us into the second stage, the chronic phase. Now, this phase can last anywhere from 2 to 10 years. Clinically speaking, it's latent, meaning a person might have zero outward symptoms. They feel totally fine. But under the surface, the virus is slowly, relentlessly chipping away at the immune system. Finally, if it's left untreated, the T cell count completely collapses, leading to the third and final stage, AIDS. To truly wrap your head around the scale of that asymptomatic chronic phase, just consider this number, 1 to 2 billion. Even when a patient feels completely healthy, their body is locked in a massive, invisible daily war. They are losing about 1 to 2 billion T cells every single day. The body is scrambling, constantly trying to replace them, but over the course of years, it just physically cannot keep up with the destruction. So, the absolutely crucial point in medicine is identifying when that tipping point occurs. A healthy, uninfected person usually has a T cell count well above 500 cells per cubic millimeter of blood. But as that invisible war drags on and the count plummets down to under 200 cells, the immune system is officially deemed severely compromised. It's at this specific threshold, under 200, that the disease officially progresses from an HIV infection into AIDS. And once the immune system is compromised to that level, opportunistic infections just take over. We call these AIDS-defining conditions. We're talking about recurrent bacterial pneumonia, severe fungal infections in the esophagus, or specific malignancies like Kaposi sarcoma, which causes severe skin lesions, and even primary lymphoma of the brain. In a healthy person, a normal immune system would easily fend these off without breaking a sweat. But with a T cell count under 200, the body's shield is basically gone. There's just no defense left.
So, how do we track this thing down? That brings us to Section 4, transmission and testing, detecting the hijacker.
Shifting our focus to the societal level for a minute, how does this virus actually spread from person to person? When you look at the data, it's very clear. Over 75% of all HIV cases are contracted through sexual intercourse. The virus is present in bodily fluids and very easily exploits mucous membranes. The remaining roughly 25% of cases happen through other means. This includes things like sharing needles during intravenous drug use, mother-to-child transmission during delivery or breastfeeding, and, much more rarely, accidental needle sticks in medical settings or through contaminated blood products. Because HIV is so good at operating in the shadows during that long chronic phase, testing is absolutely our best tool to track down the hijacker before it causes permanent damage. We've got a few clinical tests in our toolkit. We have antibody tests, which basically look for the body's reaction to the virus. We have antigen tests, which look for the physical viral proteins themselves. And we have RNA and DNA tests, which hunt down the actual genetic material of the virus. Now, if you want early detection, modern medicine highly recommends a combination antibody and antigen test. This casts the widest possible net, detecting both the virus itself and your body's immune response to it as early as possible. Which leads us to our final part today, Section 5, Managing the Virus, Our Defense. Having mapped out the whole structure of this heist, how does modern medicine actually fight back against such a resilient pathogen? Well, while it's vital to note that there is currently no cure for HIV or AIDS, we have developed a truly phenomenal defense. It's a real game changer called antiretroviral therapy, or ART. ART isn't just a single magical pill. It's a carefully calibrated combination of medicines designed to attack the virus at multiple different stages of its replication cycle. By throwing a giant wrench into the virus's ability to copy itself, RT essentially halts the destruction of T cells. This gives the immune system a much-needed chance to recover, allowing patients to live long, very healthy lives while also dramatically reducing their risk of transmitting the virus to anyone else.
So we've seen how HIV operates as an absolute master of cellular infiltration. But we've also seen how our scientific understanding has successfully transformed what used to be a uniformly fatal diagnosis into a highly manageable chronic condition. It's a stunning triumph of modern medicine for sure. But as we look at those natural genetic loopholes, like the CCR5 mutation, it begs the ultimate question. What future breakthroughs in gene editing or immunology is it going to take for us to finally cross the finish line and cure this virus once and for all? Thank you so much for joining me on this explainer. Keep asking questions, keep learning, and I'll see you next time.